Good afternoon. The patient I'll be going over is a 78-year-old Tibetan female who was admitted to the hospital on 2/14/2022 with a chief complaint of confusion and lethargy. The patient was brought to the ER today by her daughter, saying that her mother has not been active over the last couple of days as usual, but she's confused today, which is abnormal for her. During the previous day, the patient complained to her daughter about flank pain and dysuria. After being held overnight, the patient had a new fever, nausea, one incidence of vomiting, and continued flank pain. Her pain score was a 5 out of 10. The patient was subsequently given amoxicillin clavulanate 500 milligrams twice a day for urinary tract infection. Significant past medical history includes peripheral neuropathy, hypercholesteremia, and coronary artery disease. The patient denies tobacco use, alcohol use, and illicit drug use, and has no known drug allergies. Home medications include aspirin, enteric-coated 181 milligrams by mouth daily for coronary artery disease, which she's been on for 10 years. Gabapentin 100 milligrams by mouth 3 times a day for peripheral neuropathy, which she's been on for 8 years. And simvastatin 20 milligrams by mouth in the evening for cholesterol, which she's been on for 6 months. Her relevant labs include elevated white blood cell count at 15,000 cells per microliter. Her LDL is at 150 milligrams per deciliter, and her elevated serum creatinine levels are currently at 2.1 from a baseline of 1.9. All other labs are within normal limits, but her creatinine clearance is noted to be 20 milliliters per minute. In summary, we have a 78-year-old female with a chief complaint of confusion and lethargy who is treated with augmentin. The following are my assessment and pharmacotherapeutic plan for the patient. Concerning the patient's pyelonephritis, I recommend discontinuing augmentin 500 as oral beta-lactam agents are less effective than other agents for the treatment of pyelonephritis. I recommend initiating an oral sulfamethoxazole trimethoprim combination that's double strength once daily for 7 days, in addition to an initial intravenous dose of 1,000 milligrams of ceftriaxone as a long-acting parenteral agent per the Infectious Diseases Society of America practice guidelines. I would monitor with a comprehensive metabolic panel daily until the absence of bacteremia, then transition to daily monitoring with a basic metabolic panel. Follow up with a primary care provider in 1 to 2 weeks for that urinary tract infection. Concerning the patient's elevated serum creatinine, I would recommend holding simvastatin and monitoring for continued increases in the serum creatinine levels, as this could indicate the presence of an acute kidney injury. It could also indicate the presence of rhabdomyolysis, which is due to that simvastatin as well. I would follow up with the patient's primary care provider in 2 to 4 weeks regarding the hypercholesteremia because we've discontinued that simvastatin. Lastly, concerning the patient's coronary artery disease, I would recommend continuing aspirin enteric-coated 81 milligrams by mouth daily, as this is an appropriate maintenance dose for patients with coronary artery disease and chronic kidney disease per the American College of Cardiology's practice guidelines. I would also lastly follow up with the patient's primary care provider in 4 weeks for the evaluation of that coronary revascularization. Thank you very much.